pleasure to co-moderate this session with Sas Bhagwanji, who's finishing up a talk right now. So this is the plenary afternoon session, and it gives me great pleasure to introduce Chris Parshuram, clinician scientist and staff physician in critical care medicine at Hospital for Sick Children, to talk to us about the ICU resident study.
Thank you very much, and it is bright up here, isn't it? So this has been a long time in the making, and I appreciate your attention at 5 o'clock on this, the second day. So let's try and... I have a number of conflicts of interest. As a critical care physician, I do provide discretionary care from home at night. I also was involved in a number of the two North American committees on duty hours and have shares in a company that has nothing to do with duty hours. For me, the duty hours question began a decade ago when we did this study that, for lack of other good news, was heavily publicised in Canada at the time. And the message, I think, even then was clear that duty hour regulations don't prevent fatigue, and the concerns about fatigue, I think, over the last decade haven't changed. So also later that year, Chris Landrigan published the very famous New England Journal publication of 20 interns randomized to either 30-plus hour or 16-hour schedules. A number of patient days, 634 admissions, and they really focused on serious medical errors, which was a conglomerate of adverse events, preventable adverse events, and potential adverse events, in addition to mortality. And more recently, the study about which we've just heard, a study of critical care physicians was published. However, and now some time ago, the focus on residents seemed relevant, given that in Canada, this survey that we did from 2006 interviews, really more than 2/3 of overnight care in Canadian ICUs is provided by residents. So it seemed the overnight staffing question, for the time being, would benefit from a focus on the resident. So the objective of this trials group study was to compare the effect of 3 commonly used overnight duty schedules for the residents, and looking specifically at patient safety and the well-being of residents. And I think this is the tension between, there are the tensions between longer duty hours and familiarity, and longer duty hours and fatigue. And is there a balance? The other side of the equation is resident well-being. So the 3 schedules that we evaluate are schedules that are in use. The 24-hour overnight schedule, which was worked in Ontario up to 7 times in 28 days, clearly associated with acute sleep deprivation and circadian rhythm disruption. If one's staying up a lot of the night, every 4th night, that does kind of mess with your circadian cycle. Up to 75 hours a week. And the handovers, depending on whether you count the I've been there all day but wasn't looking after 3/4 of the unit, additional handovers are either 7 or 12 a week. And one doesn't work the next day, but rather has the day to recover. The 16-hour night schedule is well understood once one understands the 24-hour schedule. Instead of coming at 8:30 in the morning, one arrives at 4:30, joins the afternoon ward round. Less hours per week, still circadian rhythm disruption, but perhaps the potential to sleep in and have less acute sleep deprivation. Similar number of handovers. The nighttime schedule is 12 hours of sequentially worked nights, either 3 or 4 nights in 7, with a recovery period of 72 hours. So fewer hours per week, acute sleep deprivation potentially less, but still the same disruption on the first night, but with acclimatization, the potential for reduced circadian rhythm disruption. So these are the 3 schedules that we tried. all were in use at the time the study was done, and we had the blessing of the Resident Organisation of Ontario. So who did we involve in the study? 2 ICUs, both were willing to participate and had at least 5 residents per rotation. Both were medical surgical and had good enough patient volume for us to enable both the residents to be busy and for the outcomes we were looking for. The residents were those on their 2-month rotations who were able to do in-house call, and they didn't need to consent to be in the rotation, but needed to provide consent to provide data. And consent was waived for the patients who were admitted. So the outcomes were resident outcomes and patient outcomes. Sleepiness, using the Stanford Sleepiness Scale, we measured this every 4 hours over the 24 hours while at work on 4 randomly selected days per week. We also looked at 14 symptoms that we'd tested and found to be present, both after call but also on the day after being on overnight duty, and Maslach burnout inventory, because that's how one measures burnout. From the patient side, we looked at adverse events, preventable adverse events, and mortality. And this was done using a daily on-site prospective approach. So, the Stanford Sleepiness Scale, I think it's worth taking a moment to read through this scale. There's some perhaps Californianisms in the language, but to understand this scale is important if one is to understand the results of the study from the resident's perspective. So, and you're pretty safely anonymous from my perspective because of the bright white light, but how many in the room would describe themselves as a 3 on this scale? Awake, relaxed, responsive, but not fully alert. So here we are. So let's say that's a generous quarter of the audience, maybe not quite a quarter, but a significant proportion. And I'm not going to ask about the other rating points. These are the symptoms: headache, eye pain, blurred vision, etc. And each of the symptoms were either rated as none across to severe with constant distraction. And for the purpose of this analysis, I've identified moderate or more severe symptoms and counted the number at the 8 a.m. phase. And this is not for the overnight, this is for all residents. The adverse event we defined as is very standard: unplanned injury as a consequence of medical care that's associated with those things, harm. And the preventable adverse event was defined as the event that could have been avoided given current knowledge and standards of care. And this is defined by our expert reviewers as being more than 50-50 likely to have been a preventable event. Two-phased approach was used with daily on-site review facilitating the screening of potential adverse events, and then a retrospective physician review was performed. So the patients. We enrolled 971 ICU admission patients, and there were 49 residents, of which 2 declined to participate. 1 had been in the study previously and so was excluded, and the other declined. So leaving us with 47 residents and the nearly 1,000 patients that were reasonably evenly split between the 3 schedules. One, I think you can see the number of patients slightly less than the number of admissions, and the number of patient days is around 5,900. The residents, 15, 15, and 17, close to 20, the 20 total that were studied in the Landrigan study. So this is the sleepiness data, and I think the important immediate finding is that as the day goes across from 8 a.m. to 4 a.m., the Stanford Sleepiness Scale is here, that we get tireder. And that's an important observation, and the fact that it resonates with our everyday experience is noteworthy. The night, 24-hour night schedule is here, 16-hour is here, and the 12-hour is here. The P is actually highly significant, and the difference between the 12 and the 24-hour schedule here is about half a point, and on average we have a quarter of the room is close to that degree of sleepiness. So that's good, but let's look in more detail at the 4 a.m. data. And of course, this is where it gets more interesting and perhaps more important. So first of all, the scale is for people who are awake. And this tells us that a significant portion, about a third, of the residents were asleep at 4 a.m. And that's good, I think. It does make it more difficult to interpret the Stanford Sleepiness Scale. But also, within the different groupings, one gets a sense that greater wakefulness in the 12-hour schedule here, but even there's still some of the residents who are reporting extreme sleepiness in the preferred schedule. So here, the one-size-fits-all mantra, I think, begins to fall apart, or should I say, weaken. So, moderate symptoms, as described, about this is percent of respondents, none, up to 8 symptoms were reported. The black is the 24-hour schedule. There is a significant relationship, but it's a small proportion have more than one moderate symptom overnight. I think this warrants more reflection. And the burnout inventory. The Maslach burnout inventory is made up of 3 domains: emotional exhaustion, personal accomplishment, depersonalization. And the 1 and the 2 are the beginning and the end of the rotation. For depersonalization, personal accomplishment, emotional exhaustion, there's no statistically significant change. I think the importance of this slide is that these are not 0 at any point. So, patients, and much thanks to the University of Toronto Centre for Quality Improvement and Patient Safety for providing the funds that allowed the study to cross the line. And the patients, a lot of numbers on this slide. If you read across, the totals with percentages in red brackets are largely similar for mechanical ventilation, oscillation, non-invasive use of inotropes, vasopressors, and dialysis. The mortality varies between 21 and 16%, but is not significantly different. Here's the adverse event slide. 465 adverse events with this number of adverse events per 1,000 patient days, ranging between 76 and 81. Again, not significant. And you've probably all read the preventable adverse events numbers at this stage. Small numbers, 1, 1, and 7. But 7 of those preventable events occurred in 1 of the schedules. The consequences of the adverse events? A trend perhaps, no deaths, but a trend perhaps suggesting greater disability that persisted for more than a month in the patients in the 12-hour schedule. So the strengths, it's the largest study to date. We focused on residents, reflecting our current practice reality, and the schedules are real schedules. The study looked at multiple dimensions, some of which are not reported here, and there are a number of limitations. The intervention is unblindable. There's huge politics in this domain. Resident preferences are also important, may have influenced some of the responses, and the 12-hour schedule, as much as shorter is better, was actually the least popular. So for patients, shorter might be the same, it might be worse. The adverse events were the same, but there were some concerning and counterintuitive trends observed. limited statistical power for these analyses, I really would like to emphasise. And I think it's also important we focused on one very small group in a very large group of healthcare professional experts. So for residents, statistically significant differences in sleepiness, but really, is it clinically significant? And I think this warrants consideration. The meaningfully important difference in Stanford Sleepiness Scale of 0.5 point on average is probably overstated here. Burnout was high, and symptoms are significant in all groups. For others, we haven't discussed, and those significant others at home, interestingly again, I heard anecdotally the 12-hour schedule is least popular. The study team, there are members missing, but I'd like to thank them, the Canadian Critical Care Trials Group, and the staff and patients at the two hospitals, Mount Sinai and St. Michael's. And thank you.
Thanks very much, Chris. We'll move immediately to editorial comment on this study by Dr. Scott Halpern from University of Pennsylvania. And then after that, we'll have time for some questions.
Okay, thank you, Chris. As I said, congratulations on a really nice study. These studies require an incredible amount of work, time, perseverance, and patience, as you nicely alliterated on. So I'm really going to focus my comments primarily on sort of background and context, what else we know in the area, and make a few brief comments about the specific study. So to start, so how did we get here? Some of you may know this history, but in case not, so there was a young girl named Libby Zion who had a really tragic event in New York. She died from what was later discerned on root cause analysis to be serotonin syndrome, given administration of an SSRI in hospital that interacted with a drug that she was taking as an outpatient. This happened in 1984. This led to the Bell Commission, which many of you may have heard of, that reviewed this case, did the root cause analysis. They identified several factors that were potentially related to the unfortunate death of Libby. It turns out that resident fatigue really wasn't high on the list at all. So it was like number 18 on the list. What was highest on the list was likely imperfect supervision of the intern who administered the drug. But that's pretty hard to intervene on. So what they did instead was they said, well, let's intervene on what we think we can intervene on, which is resident work hours. And that's what led New York State to adopt the 80-hour workweek rule in 1989. The primary response, as I said, has been progressive duty hour restrictions. The United States Association for what is ACGME? Accreditation Council for Graduate Medical Education issued its 80-hour workweek recommendations in 2003, and then modified them further in 2011, where they said that the maximal shift for interns would be 16 hours. There are a variety of other rules and regs under these criteria that I won't bore you with right now, but the two cornerstones are the 80-hour workweek and now the 16-hour maximal shift for interns. So this is the Brigham and Women's study that Chris alluded to. So Brigham and Women's is a hospital in Boston. It's actually right across the street from the editorial offices of the New England Journal, conveniently enough. And so they got two papers out of this study. One looking at sleep. So you can see on the plot on your left, you see the open circles are interns in the intervention schedule, which is the shorter work hour schedule, and the black circles are in the traditional schedule. You can see that in the traditional schedule, nearly all of them are working more than 80 hours a week, and in the intervention schedule, nearly all of them are working fewer than 80 hours a week. And you can see that that was associated with some differences in the mean duration of sleep each week. What it was also associated with is reduction in serious medical errors made by interns, as well as serious medical errors overall. But what's interesting is that despite large and statistically significant differences in these quote-unquote errors, there were no differences in preventable adverse events for patients. Now, there were some trends maybe in that direction if you're an optimist, or, well, I don't know if it's optimistic or pessimistic. If you're a believer, I should say, if your priors accord with this being a good thing, then you might say that there were trends in that direction, but certainly no statistically significant differences. A little more evidence, some that I find particularly interesting. So on the left here is a study by Kevin Volpe that was in JAMA in 2007, where they looked at Medicare data using, for the econometricians in the audience, a difference in differences approach, where they basically take the following analytic approach. They take hospitals who had patients who were Medicare beneficiaries, and so this is 200 million patients in this data set, and they looked at hospitals by their teaching intensity. And what they basically hypothesized is at the time of implementation of the 2003 duty hour reforms, if residents working fewer hours is a good thing, then you should see preferential declines in mortality among those hospitals with high resident penetration. Whereas you shouldn't see the same decline, or you should at least see a different pattern in non-teaching hospitals. But instead what they see is no change whatsoever regardless of teaching intensity, and if anything, the dark black line is at the top, is a little bit of an outlier actually, suggesting less of an overall decline over time than actually the lower teaching hospitals. So certainly nothing to suggest there that patient outcomes were improved by fewer resident work hours. And then just recently, this paper was published out of Johns Hopkins, where they did a randomized trial basically focusing on the intern call schedule. And this comparison of just the 24-hour shift versus essentially a 12-hour night float shift, analogous to what Chris described, found much lower satisfaction with educational experience among the residents, and really dramatic differences in nurses' perceptions of the quality of care. So much so, in fact, that they actually stopped the night float arm prematurely because they were so concerned about the reports they were hearing from the nurses. So, on to Chris's study. He really described it eloquently, so I don't really have much to add here. He went through the three arms of the trial and the primary and secondary outcomes. A couple strengths and limitations that I will comment on. First is, I thought they did an absolutely amazing job prospectively screening for adverse events. It was a very, very systematic approach that required lots of time and energy among some very well-trained nurses who knew what to look for, and they were looking for it in real time. This is, I think, the best study to date in terms of the methods used for screening for adverse events. Second, the adjudicators, the nurses, and then also the physicians on the back end were very well trained. There was a very elegant process put in place to ensure that people were sort of speaking the same language and were calling an adverse event in the same way and defining preventability similarly. Again, I think another tremendous strength of the study is sort of the outcome classification scheme. Additionally, although the study was not randomized, there was reasonably good balance. I think, and Chris did present these data, reasonably good balance of key covariates, and a very nice job of appropriate risk adjustment. So, although one can never rule out the possibility of residual confounding in an observation, not an observational, but a non-randomized study, I at least don't think that there is residual confounding going on here. At least I'd be surprised. A couple limitations that I would point out. So one is the resident outcomes are all subjective. I'm fine with the Stanford Sleepiness Scale. My wife went to Stanford for her undergrad, but it's pretty squishy, right? So a lot of studies in this space are using outcomes like actigraphy, so you wear a watch that actually tells people how often you're sleeping as a method of discerning whether sleep schedules are actually changed by this intervention, and then polysomnographic vigilance testing, which is how quickly you can hit a button in response to a stimulus as a measure of alertness. And unfortunately, these sort of more objective measures of sleepiness and sleep health, or sleep well-being, if you will, weren't employed in this study. And then second, I would say that there were no data on residents' long-term outcomes, which just means that Chris's study is like every other study that's been done in this space. I think these are really important outcomes that we care about. So we care about what happens to patients today, But I think we also care about what happens to patients tomorrow when the residents that we're training under these different staffing models are now out in practice and not being supervised. And we don't really know yet what happens to patients cared for by these residents who've been trained in different ways. Chris alluded to the parallel story here. I think there are a lot of similarities in these two evidence bases that are developing somewhat in parallel. And I would just, again, reiterate the idea that there may be tensions between the safety of patients today and the safety of patients tomorrow. And I think if we're really going to move forward in a fruitful direction as a field, studying how to train residents in terms of what, not just work hours, but in terms of the amount of supervision and infringements on autonomy, and as Andre Amaral talked about earlier, like how we actually go about doing the handovers that are likely to occur, we really need to take into account these potential trade-offs. And I will actually stop there in the interest of time. Thank you.
Thanks very much. I think we're open for questions here. People want to come up to the mics. Maybe while we're doing that, I'll start with a question. Chris, did you also, you mentioned that you had some anecdotal reports on effect on popularity of the schedule at home and so on. Did you also look at more formally at effects on nursing perceptions and on consultant perceptions, both of resident performance and their own workload?
Yes. So we did a number of additional, thank you, if one wasn't enough. We did a number of additional surveys of perception, including perceptions of and descriptions of continuity on a patient-by-patient basis. We looked at family perceptions of continuity and familiarity, and also the nursing and respiratory therapy staff's perceptions of staff engagement and their involvement, data that I've not presented here. So these additional components are formally reported, but in addition there was a strong, and now I'm reporting very anecdotally, preference against or preference to avoid the 12-hour overnight schedule. The residents reported feeling disconnected with the patient care team. So I think these social elements are also very important considerations as we move into a very resident-driven, at least in some jurisdictions, process for change into of the call schedules.
Great.
Sue Moffat from Queens. I believe the Quebec interns and residents have also done a similar study, which you probably know of, in which they also looked at the resident satisfaction and how the shorter duty hours actually screwed up their life. That they came back to work more often to go to teaching, that their home life suffered from this. And there was quite a...
More vigilant in that they're reporting, maybe they were acting tough and they didn't want to report the degree of sleepiness, perhaps speaking to the requirement for some more objective testing that you know, for practical reasons others weren't done.
So the risk of the Hawthorne effect was something that I was quite concerned about early on, especially when 2 study personnel, or in fact in the first week, 3 or 4 study personnel would join with approval the daily ward round and 1 person at the weekend. What became apparent very rapidly is we were, and they, were accepted as part of the team and became, I wouldn't say invisible, but certainly the conversations that I was hearing were very consistent with conversations I would have expected to have heard on a unobserved ward round. So there was acclimatization fairly rapidly. We took great care to preserve the confidentiality of the resident responses and with view to minimizing any potential concerns they had. And there was also a process put in place if the residents felt that coercion for participation or any other influence of the study on their academic or other interactions in the ICU. This was not observed, and I think rapidly I became very comfortable with the fact that it was business as usual as much with observation.
Hi, Chris. So great to see that you've finally reached this stage after a lot of work. So in terms of adverse events, it's obviously a balance between resident alertness and errors related to handover. In retrospect, do you think there would have been a benefit to spending more time on education on handover and perhaps planning or formalizing the handover more?
I'm not sure. I'm not sure that the answer is yes. The fact that we found no difference, if we changed the handover actively, would it have been the handover that was the mechanism of effect? I think the handovers continued as they were, and the systems within the ICUs, the residents adjusted their approaches. So I think a multifaceted intervention would have been even more challenging to have delivered. And at the time, we didn't have good handover tools to just say, do this as an add-on. What do you think? You were one of the attendings.
Yeah, just that 12-hour shift handover, which was a resident-to-resident handover, was always poor, that the next morning the overnight resident did things without clearly understanding the patient's problems.
Mm-hmm. And do you think this is a handover issue or a supervision issue, he said provocatively?
I really don't know, but the handover did stand out, that it was striking that the 16-hour shift was a handover between the attending physician and the overnight person, but the 12-hour shift was one resident who stayed later handed over to the overnight resident, and they just didn't get it.
Chris, can I ask, are there any parallel studies from industry where you've got shift workers who are changing from day to night shift, and what sort of findings they might have come up with? I think like at the airline industry where they're constantly day-night shift changes.
Mm-hmm. I'm less immediately familiar with the results of nursing studies where 12 versus longer than 12 or 12 versus 8-hour shifts have been compared, which I think is largely American literature. And I think the longer than 12 is certainly bad, but I don't know the results well enough at this stage to tell you. Do you know?
Sorry, Chris, was there any difference in the level of supervision between the three groups, given that there was a difference in the...
Mm-hmm. As best as we could tell from the survey data, the supervision remained constant.
Yeah, one point I'd make on that, there was an interesting series of correspondences after the Brigham and Women's randomized trial was published, where 3 residents from that hospital who had been part of the study actually wrote a letter to the editor in response saying that they didn't believe any of the data, which I think had tremendous audacity for residents in that health system. But anyway, what they perceived was that in response to the reduced work hours and increased handoffs among the interns in the intervention period, that the attending intensivists and critical care fellows got more hypervigilant and overcompensated for what they perceived to be an inadequate intern supervision schedule, and they believe that that accounted for the perceived benefits in the intervention schedule. I have no idea the extent to which that might have been at play here, but it was a very interesting and well-written letter to the editor.
I think the problem is that it definitely alters the higher level supervision and the role of other team players. So at our institution, we have nocturnists, and it's yet another level of handoff that needs to happen. And there's a 30 to 50% increase in handoffs with these new hours. So it's a very significant problem, I think, because of that. So I'm interested that you didn't actually see a significant difference. But I would believe that that's a problem, because they don't call the attending, they call the nocturnist, who knows even less than the resident sometimes.
We have one last question from Dr. Kavanagh.
Thank you very much. Brian Kavanagh, Toronto. Chris, that's a great study. Everybody gripes about the system, and you actually got it funded and designed and completed, so a huge achievement. Can I ask you, how do the preventable adverse events, how does the frequency of that in your study compare with what's claimed by IHI, for example?
In fact, if I could have my slides back.
You can just tell me, greater, same, or worse.
The Landrigan study reported adverse events of nearly the same. They had a non-significant difference, but the overall rate was almost identical to that we found in the 3 schedules. What was different, however, was the rate of preventable adverse events that was significantly, the proportion was significantly lower, and as was the absolute rate compared with our American colleagues. And out of respect for my colleague, I didn't make any geographical observations about the significance of this data.
But the house staff you're talking about are residents, whereas Landrigan's study was interns, correct?
Yes, that's correct. And I think it's an important distinction. Interns in the ICU are uncommon as the sole intensive care staff, physician staffing overnight in Canada. And certainly in many ICUs, interns don't go there.
Thanks.
All right, well, thanks very much. Again, I'd like to echo the congratulations due on this fantastic study, and also thank Scott for his very thoughtful editorial comments. Thanks very much. I think it's because Canadian reviewers don't think anything's preventable.
Yes, that's right. But can I say that? Oh,